2, 1. Please start, sir. We are live.
Yeah, so good evening, everyone. And it is my pleasure to introduce Dr. Mihir Vaidya, a renowned ophthalmologist and vitreoretinal surgeon with over 10 years of experience in comprehensive eye care. Dr. Vaidya has received advanced fellowship training in vitreoretinal surgery as well as advanced cataract surgery. He has previously served as a vitreoretinal surgeon, uveitis and ROP specialist at Sion Hospital and also at Bachuali Eye Hospital, Parel. And Dr. Vaidya has also been recognized with multiple research awards, published several scientific papers, and actively mentors young ophthalmologists. And so with this, I welcome Dr. Mihir Vaidya for his presentation today. And over to you, sir.
Hello. So I'll just share my screen.
Sure, sir.
It is visible, sir.
It's visible, right? Okay. So today I'll be discussing aflibercept in a treat and extend regimen being given for neovascular age-related macular degeneration. And I'll be focusing on how it is durable and how we can reduce the treatment burden. So I have no financial interest in this talk. And age-related macular degeneration basically is a chronic disease and it requires long-term treatment and monitoring. So it is divided into the dry and the wet types. The features of dry are drusen, RP atrophy, early, intermediate, and late are the classifications. When we talk about wet AMD, the striking OCT features are CNVM, PED, which is a fibrovascular PED, intraretinal and subretinal fluid, macular hemorrhage, and subretinal hyperreflective material. And finally, if not treated well, it can scar. PCV, that is polypoidal choroidal vasculopathy, which is now known as a part of the pachychoroid spectrum, is practically treated as a wet AMD only. It is more common in Asians. So dry is treated with the antioxidants, vitamins, and minerals which are there in the AREDS2 formula, and frequent monitoring, depending on the stage, is advised. When we talk about wet AMD, it is treated with anti-VEGF injections and photodynamic therapy. Nowadays, only anti-VEGF injections. So here we'll see the OCT features and the fluid distribution in the case of neovascular age-related macular degeneration. So I'll just use my pointer. So here what we have to do is we have to follow these three hyperreflective lines. The first one here, which is on the inside, is the external limiting membrane. Then comes the ellipsoid zone. And then the thicker one, the brightest one, is the RPE Brooks complex. So this space, which is under the RPE and over the Brooks, this one, this is the sub-RPE space, and we can see a RPE detachment here in which there is a fibrovascular PED between the RPE and the Brooks membrane. If we trace the second hyperreflective line here, the middle one, it goes up and here it comes like this. So this space, which is between the ellipsoid zone and the RPE, is the subretinal space, and here we can see accumulation of subretinal fluid. Here also we can see some subretinal fluid. And here between the layers of the retina, what we can see is intraretinal fluid. Now, fluid hyperreflective material, which could be an exudation or some debris, which can get accumulated underneath the retina or underneath the RPE. So basically, it gets accumulated in either the subretinal space or the RPE and Brooks, which we call the PED. So what are the current unmet needs in the treatment of patients having neovascular AMD? Despite effective anti-VEGF therapy, the biggest unmet need right now is the treatment burden. Over 70% of the clinicians highlighted injection frequency as their main concern. And this is the concern for the patients also. So this slide, what we see here is that this is a study by Fauser et al., in which levels of anti-VEGF were measured in the anterior chamber, like in the aqueous. And this graph shows the suppression of VEGF after an injection has been given. What we can see is that there is a significant interpatient variability in the VEGF suppression, and that is ranging up to 16 weeks. This clearly supports the need for an individualized treatment. The anti-VEGFs currently available are bevacizumab, that is Avastin, ranibizumab, marketed as Accentrix or Lucentis, brolucizumab or Pegenax, aflibercept, Eylea, faricimab, which is marketed as Vabysmo, and then there are biosimilars. So the first three here, they bind to VEGF-A. Aflibercept binds to VEGF-A, VEGF-B, and PIGF. Faricimab binds to two receptors, that is Ang2 in addition to the VEGF-A of ranibizumab. So individual things that are of importance of these molecules are that brolucizumab is a smaller molecule and theoretically higher molar dosing can be given. That improves the tissue penetration for these. When we talk about Eylea, and here there is, as it binds to multiple receptors, there is broader binding which can translate to a increased durability of action. Faricimab with Ang2 in addition to VEGF-A gives us a dual pathway targeting. The regimens that we use currently are fixed dosing, ProRenata, and treat and extend. Fixed dosing means that we are giving the injections at a fixed dosing. If we have decided 1 monthly injections, then we continue it 1 monthly. If we have decided 2 monthly, then we continue it 2 monthly. We do not modify or modulate the injection schedule according to how the response of the injection is. ProRenata translates to as and when required, and basically it means we inject when wet. That is, when there is an activity in the form of subretinal or an intraretinal fluid, that is the time to inject. In treat and extend, it is slightly different. This is a proactive extension, maintenance, or shortening of the interval between injections, depending on how the patient is responding. So how do we implement a treat and extend regimen in clinical practice? It is a proactive strategy, and in which what we do is we treat until it is stable, and then what we do is extend the interval between injections. We keep on extending until the fluid recurs or the visual acuity declines, and then later we can decrease the interval to a previous stable interval when the activity is not there. So talking about the durability of current anti-VEGFs, these are the studies which were conducted for ranibizumab, treat and extend. So as we can see that across multiple studies like TREX, CANTREAT, LUCAS, and FLUID, we see that there are visual gains are maintained. It's not like the vision is going away. Visual gains are maintained over 2 years, and they are roughly in the range of around 6 to 9 ETDRS letters in most cohorts. However, what we can see here is the number of injections that are given over 2 years. Around 16 to 19 injections were required over 2 years. So 16 to 19 injections in 24 months means that it is almost equal to a monthly or a bi-monthly therapy in the long run. And as we know that frequency of injections is the biggest burden and the major concern of the patients and the doctors, then that is why this 16 to 19 injections becomes difficult. Now let's talk about HAWK and Harriers, which were the studies conducted for brolucizumab. At week 16, here what we can see is that around 75, here 76 and 77, so around 75% of the patients were on Q12 dosing. What does Q12 mean? Q12 means 12 weekly, and that is 12 weeks are approximately 3 months. But by week 96, there is a big drop in those who could be maintained on this Q12 schedule. Here we can see around 40% of the patients are being maintained at week 96. And what we can see here is brolucizumab 6 milligrams was given and 10 injections were used over 2 years. And when we gave aflibercept, around 11.7 injections were required. But we'll see later that aflibercept had a higher proportion of patients who could be maintained to a Q12 or even a Q16 dosing regimen. So this is the data of TENAYA and LUCERNE trials. And what it says is by the year 2, in about 1 in 4 patients could not be extended beyond the 8-week dosing. And when we compare fixed Q8 regimens, faricimab may actually require slightly more injections than aflibercept, and that is due to the extra loading dose, which we'll see in the next slide. So here, as you can see, faricimab, 4 injections is the loading dose, and aflibercept 3 injections are the standard loading dose. However, comparing these two trials is not ideal because of a couple of reasons. Maybe 2 or 3 reasons are there, in which the first one is here faricimab treat and extend was compared with an aflibercept Q8 fixed dosing regimen. Second thing is that here 4 injections were there in the loading dose, and here around 3 injections were there in the loading dose. So the trial design is completely different. And third thing is that faricimab here was tried in 2 dosings. The one was the 6 milligrams, with the results of which are shown here, and the lower dosing of 1.5 milligrams is not shown here. So the FDA faricimab summary review said that these studies simply show that some patients are very responsive to anti-VEGF therapies and may be dosed less frequently, which is already known from clinical practice. Now let's come to ALTAIR, which is the topic of discussion today. So what is the ALTAIR trial? This is named after one of the biggest stars visible in the sky. This is not an acronym for anything. And what we compare here is the treat and extend, 2 types of treat and extend dosing regimens given for aflibercept. So first 3 injections were given at 1 month intervals. Then the 4th injection was given at the 16th week. And after that, there was a randomization of the patients in which one group was given a 2 weekly treat and extend, which means that if we want to extend or shorten the interval in this group, we would do it by 2 weeks. And in this group, the other one, we would do it by 4 weeks. So how does it work exactly? What we have to know is that when do we maintain interval? When the disease is improving, but it is not completely resolved. So what I mean by that is we have given an injection, but the disease is still not completely resolved. That means there is some amount of activity in the forms of fluid, subretinal or intraretinal or an amorphous shrimp. Then there is, when do we shorten the interval? If we see worsening of the disease at any given point of time and compare, if we see the OCT, compare it to the previous OCT, and we see that the fluid has increased or there is a fluid at a different location, then that is the time to shorten the interval between 2 injections. And when do we extend it? We extend when no sign of activity, that is, no fluid is present. So few things are seen for activity. One is the fluid. Then is there a significant increase or decrease of CRT, that is more than 100 microns. And the third thing is new neovascularization or a new macular hemorrhage. So ALTAIR, if we see here, so this is the data of the 2-week group and this is the data of the 4-week group. So the ETDRS letters visual acuity improved by 7.6 in the 2-week group and 6.1 in the 4-week group. Approximately 10.4 injections were required in both the groups. And this tells us about the proportion of patients at Q16 intervals during the final visit. Here, 41.5% of the patients could be maintained, and here 46. So around 45% of the patients could still be maintained at a Q16 interval at week 96. Q16 means it is 4 months. So the durability is quite good here in this trial. Then in this study, what we can see is that the mean last injection interval is shown here. It is 12.2 and 12.5. Around 12 weeks it is maintained. And if we see by week 96, around 60% of the patients were maintained at an injection interval of 12 weeks and beyond. As we already saw, this is how many could be maintained at Q16, and Q12 and beyond, it comes to around 60%. So this shows that 96% of the patients who were extended to the Q16 could be maintained at this interval with aflibercept. So it is not just up to carrying the patients up to a Q16 interval, but also maintaining it. And 96% of the patients in whom we are successfully giving the injections 4 monthly, we are able to maintain it. So here, what we can see is that there is a clear reduction in the injections in year 2. And firstly, we'll look at the visual acuity. So visual acuity here and here is pretty much maintained. So at first primary endpoint, which is 52 weeks, and here at 96 weeks, the visual acuity is maintained. The improvement in vision is good. And If we see here, we are giving around in the first year, we are giving around 6 to 7 injections, and here we are giving around 4 to 5 injections. Now, why this slide becomes important from the clinical point of view is whenever a patient comes to us, the one thing that he will ask when we are initiating a therapy, or even when the patient is somewhere in the middle, he will ask how many more injections. So we have to tell the patient that it is definitely individualized as a treatment, and with every patient we cannot 100% predict it, but there is a data with this regimen that shows that around 6 to 7 injections will be required in the first year, and in the next year will require around 3 to 5 injections. So that way the patient also has an idea, and the questions and the doubts are all answered, and the patient can plan. Can aflibercept achieve RCT-like outcomes in clinical practice? So that means, can we actually replicate this in a real-world practice? So this is a study by Jaggi et al. And it showed us that with a structured protocol-driven approach, about 35% of the patients can actually stop injections after achieving a sustained stability at longer intervals, which means when the exit criteria is met, that is 3 times when we are maintaining on a Q12, and injections are not required, then we can stop the injections. And by stopping, it does not mean that we are completely curing the disease, but it is a prolonged treatment-free interval with continued monitoring. So treat and extend is not just about extending intervals. It can, in selected patients, reduce the burden to the point of temporary treatment cessation while maintaining good outcomes. So this is a study by Maruko et al., in which what we can see that the mean number of injections over first year is around 7.4, and by 2 years, the patient has received around 13 injections, which is very much in collaboration with our data, that is 6 to 7 in the first year and around 4 to 5 in the next year. And by year 2, 60% of the eyes were being treated at an interval of 3 months. So the injection burden and the is reduced, and the interval between injections is maintained in 60% of the patients. This is a study by Taipale et al., in which what we can see is he did 2 regimens, that is treat and extension of moderately, and this is treat and rapid extension. So both of them maintained the visual acuity, and around 14 injections were required in the moderate extension group and around 11 in the rapid extension group in 2 years. So in another study by Itagaki et al., up to 75% of the patients could reach around 3 monthly intervals at 3 years also. And this shows us a data of 3 years. What it says is that it achieved around 17 injections in AMD and PCV patients over 3 years. And 75% of the eyes could be extended to 3 months. And in this study, it also told us that in 60% of all cases, of all the cases that were studied, 16 weekly intervals could be achieved, and in around 79% of the PCV variant cases, it could be achieved. Now, PCV forms an important disease when it comes to the Asian population, and we see it a lot, and these numbers are really encouraging. The number of injections given in 2 years averaged at around 11. Let's look at some more real-world evidence. Now, why is real-world evidence so important? It is important because it refers to outcomes from routine clinical practice, and it reflects how treatments perform in the real world rather than in a controlled trial setting. So across studies, multiple studies and multiple clinic-based trials, consistent durability with aflibercept has been observed. So this is one slide in which I have summarized all the anti-VEGF trials for an AMD, and it's not about the trial design, this, that, etc., but what was the conclusion or the practical insights from each. And this would be an important slide from the point of view of remembering every trial shortly and what it tells us. So Marina, first let us look at ranibizumab. Marina told us that ranibizumab is effective. What Anchor told us that it was superior to PDT, and that is why we could replace PDT. The CAT trial told us that efficacy was comparable to bevacizumab. The PEER trial told us that 3 monthly dosing after loading dose was not really the strategy that we could use if we were giving ranibizumab because the efficacy was lost. And Harbor trial told us that higher dose of 2 milligrams if given, normally it is 0.5. So if higher dose was given, it was not providing any added benefit with ranibizumab. Aflibercept, we have the VIEW 1 and VIEW 2 trials. Now these two VIEW trials were Q8 regimens, and aflibercept was non-inferior to monthly ranibizumab. The Altair trial we discussed in detail, and it told us that treat and extend up to Q12 or Q16 is really feasible. ARISE trial told us that an early treat and extend is as effective as a delayed treat and extend. So no need to delay the treat and extend regimen. After we have given the loading doses, that is the time to start. And Hawk and Harrier for brolucizumab, they told us about the Q12 weekly durability. But there was one issue here, that in the post-marketing safety trials, the risk of vitritis and retinal vasculitis could be identified. Faricimab, which is the new drug on the block, we have Tenaya, Lucerne, Stairway, and Avenue. So Tenaya and Lucerne compared TNE of faricimab to a fixed Q8 of aflibercept. Mind you, as we already said, it never compared treat and extend of faricimab to a treat and extend of aflibercept. And that is why it is not a very fair comparison with aflibercept, because there were patients who were being Q8, who were being given doses Q at 8 weekly intervals, but they could be actually extended, but the chance of extension was not really given. Then Stairway supported extended interval strategy, and Avenue trial compared faricimab again with the first drug ranibizumab, and it confirmed its dual pathway approach. So to conclude, aflibercept has set a higher bar for patient outcomes in clinical trials, with proven efficacy in the clinic also. What I would like to say is that ultimately the goal is not just to treat, but to treat smarter. And treat and extend regimen allows us to do so. In neovascular age-related macular degeneration, management of these patients, injection frequency is what defines the treatment burden actually, and optimizing durability is something which truly improves patient care. So thank you.
Thank you, Dr. Mihir, for the excellent and very insightful presentation on treat and extend. And we now move on to our next topic, and it's my pleasure to introduce our next speaker, Dr. Abhishek Heranjal, a consultant vitreoretinal surgeon and ROP specialist with expertise in the diagnosis and management of retinal diseases, including diabetic retinopathy, retinal detachment, macular disorders, uveitis, and ROP. Dr. Heranjal has undergone advanced fellowship training in vitreoretinal surgery and ROP at Bachuwali Eye Hospital, Mumbai. He has received several academic awards, published research in leading international ophthalmology journals, and is actively involved in community eye care through the Abhisham Foundation. So with this, I welcome Dr. Heranjal for his presentation. Over to you, sir.
Thank you so much. So once we are done with neovascular AMD, now we move on to something which is very common. Can you see my screen?
Yes, sir.
Yes, sir. It is visible.
Visible.
The slides are visible, right? Yeah. Okay. So good evening, everyone. So now when we are done with neovascular AMD, we are coming to the most common topic that we face day to day, that is diabetic macular edema. And as we all know, initially diabetic macular edema was also called as CSME, and now the terms have changed to diabetic macular edema, and we just look at whether it is center involving or non-center involving. So let's understand more about diabetic macular edema from clinical point of view. And I have no financial disclosures here, and these slides are basically just for scientific and research purposes. And I hope we all learn something from this. So diabetes, as we all know, is the fourth most common cause of non-communicable disease deaths worldwide, and after cardiovascular deaths, cancer, and respiratory disease. So what I want to highlight here is that India is the emerging diabetic capital of the world, and we as practicing Indians, we will get to see a lot of diabetic patients in a clinic who will sometime or other develop something called as diabetic retinopathy, and they may have a condition called as diabetic macular edema. So why is it important to us? This risk of diabetes has risen to more than 35 to 45% over a decade, and it is on a constant rise. And the numbers that have been predicted here are just assumptions. It might be much more than what has been predicted. As we all know that every third person in our clinic who is coming to us is a diabetic, and we might get a patient who has diabetic retinopathy. So what is DME, or diabetic macular edema? So whenever there is a presence of fluid at the macular region, it can cause an increase in the thickness of the retina, thereby causing a loss of visual function, and hence this term is called as diabetic macular edema. So DME occurs when the blood vessels in the retina leak fluid or proteins into the macula and cause the macula to swell. So what I usually tell my patients is that imagine your macula is like a sponge. When you pour more water over it, it will swell. And that is what happens in diabetic retinopathy. So whenever there is vascular leakage, there will be some fluid which will egress. There will be some exudates that will come over the retina, and that will be absorbed by the retina, causing retinal thickening and swelling. So this is what is diabetic macular edema. The key indicators or key factors that causes an increase in DME is VEGF-A, that is vascular endothelial growth factor A. Also interleukin 6, also VEGF-B, interleukins, and some placental growth factors that can cause increase in diabetic macular edema. So why is it important? Most of our patients developing diabetic macular edema are at the younger age group. So they're all working population who will face difficulty in reading, who will have difficulty in driving, who will have difficulty in identifying colors because the central vision is hampered. And that is why it is important that we treat these patients early so that they can have better vision and work effectively. So what happens if you leave these patients untreated? If the patients with diabetic macular edema are left untreated, they may develop an end-case treatment wherein there is exuberant macular ischemia and cause a depletion of foveal avascular zone, thereby causing permanent blind spot at the center. So it is very important that these vessels are repaired in time, and with the upcoming treatments and the treatments that we have as of now, it is possible that we can regain their normal visual function and have a good central vision. So earlier, when we were treating diabetic macular edema, we did not have treatment options like the anti-VEGFs or steroids. We only had one treatment option, that was lasers. So wherever you see a leaking microorganism, the only treatment that used to be given was lasers or focal lasers, which we all know that post lasers, there will be a permanent blind spot, and with time, these laser scars increase in size also to up to 2 to 3 times. That is when patients usually have some central vision loss, but at least securing some useful vision so that they can carry forward with their daily work routine. But with the advent of anti-VEGFs that Dr. Mihir described earlier, Avastin, ranibizumab, Excentrix, Eylea, now Vabysmo and faricimab, all these treatment regimes have improved, and we are now telling our patients that you can get useful vision with just a small injection in your eye, which will last for a very long duration depending on your systemic status and control. So initially it was only lasers, then there was anti-VEGFs, and also implants like Illuvin and dexamethasone or Ozurdex. The treatment has helped us achieve better visions over time. So what factors drive key mechanisms behind the pathogenesis of DME? So we all have to understand that the mechanism of VEGF to cause vascular leakage is via the VEGF receptor arms, and it has two arms, VEGF-A and VEGF-A arm, that is arm 1 and arm 2. So the VEGF-A usually binds to the VEGF receptor arm 2, and the placental growth factor usually acts either by acting directly at the arm 1 or by displacing VEGF-A at arm 1 and indirectly acting via the VEGF receptor arm 2. So what happens, these VEGF receptors at the tight junctions cause a change in vascular permeability and thereby having a lot of vascular leakage. So excessive activation of the VEGF receptor 1 and VEGF receptor 2 can result in increased vascular leakage and edema, and thereby increased inflammation and a pathological development of neovascularization. So this is a pathophysiology of how diabetic macular edema develops. So as we all know that in diabetic patients, we all have an hypoxic retina because of a decreased blood flow, which which causes a release of VEGF factors, VEGF A and B, and also placental growth factor, which causes an increased inflammation, thereby causing chronic inflammation and RP cell damage. Also, VEGF A causes damage to the endothelial cells, causing a disruption in the blood retinal barrier, thereby causing more vascular leakage and edema. Also, with time, this hypoxia will lead to development of newer blood vessels, which will be abnormal, called as neovascularization, which further will increase the burden of VEGF inside the vitreous cavity, thereby leading to increased edema and further advancement of diabetic retinopathy. So, understanding the pathophysiology of diabetic macular edema is very important, as when we want to treat these patients, you have to tell them that it is a systemic disease that has to be controlled over time, not only with the help of treatment that we give, but also with their daily lifestyle modification that they have to undergo. So, with all the anti-VEGFs that are there in the market, VEGF A, B, and placental growth factor is blocked by aflibercept, whereas brolucizumab, ranibizumab just binds to VEGF A. The newer molecule, that is faricimab, Vabysmo, that binds to VEGF A and a newer protein, that is ANG2. But the only molecule presently in our armamentarium is aflibercept, which binds to all these three, thereby giving a better better result than compared to the other molecules. So in summary, VEGF A, B, and placental growth factor are the key drivers behind the pathogenesis of DME, and aflibercept is the only globally available anti-VEGF agent that targets multiple mediators of this retinal disease. So there are several sources of evidence that support this anti-VEGF choice. There are multiple random RCT trials that have been done. There is enough real-world evidence now that we have that aflibercept is doing great. There are multiple meta-analyses that have proved that it is superior to other anti-VEGFs that are there in the market. There are international guidelines that have recommended that aflibercept should be the drug of choice in DME. The mode of action is clear to us, and our own experience is also supporting the same thing, and it is data-driven. So it is very important to understand that timely and effective treatment for all patients with DME is done, and so that they have a long-term visual recovery. So there are some landmark studies that were done to prove that Eylea is more superior and better than the earlier treatments. We have the VIVID and VISTA trial, wherein initially 3 monthly injections or 5 monthly injections were given to the patients, followed by either a 4 weekly or 8 weekly interval injections, wherein the mean change in best corrected visual acuity from baseline at the 1 year interval was around 10 to 12 letters improvement. And the mean number of injections received in these groups were around 8 injections. So what we understood from this trial is that vision gains were observed as early as with the first injection. So the worse the visual acuity, the better the gain, or the decrease in CFT was realized after the first injection. Patients received more than 8 injections through first year, and that maintained the visual gains throughout the initial loading phase. So what we have to understand here is, despite having a loading dose of 3 or 5 injections, what the patients observed was immediately after the first injection, they had a very good visual gain, which was maintained throughout the interval in year 1. So at 52 years, that is at the end of 1 year, aflibercept demonstrated that it was very much superior to lasers, which was earlier only the gold standard for treatment of DME. And hence, we have shifted our treatment from focal lasers to giving injections. So these are the patients who had a consistent visual gain of more than 10 letters over a period of 1 year. And in the later part of the study, at year 2, they have also included patients who had received lasers and then switched to aflibercept, But as we see the gray line over here, these patients never had the visual recovery as the patients who had initially received the aflibercept injection at the very beginning. So that is the importance of early treatment. So what is the take in VIVID and VISTA trial, that even if you start injecting at a later phase when the vision has already depleted, you might not receive the same outcome as you expected in this trial. So it is very important that the patients need to be treated at a very early stage, and persistent treatment is the key to success. So what do meta-analysis and expert international guidelines recommend for the treatment of DME? So Cochrane meta-analysis reviewed evidences from major studies that were investigating the efficacies of anti-VEGF agents across DME. So they included around 24 studies and over 6,000 patients with DME who had visual acuity of less than 660 to 612. And what were the conclusions? At first year, all efficacy outcomes significantly favored aflibercept over ranibizumab and bevacizumab. Patients were approximately 30% more likely to gain more than 3 lines improvement with aflibercept than compared with ranibizumab and bevacizumab over 1 year. Anti-VEGF agents did not differ regarding the same in year 1 or year 2 follow-ups. So other meta-analysis also showed that aflibercept over 8 weekly intervals showed evidence of superiority compared with ranibizumab at PRN regime for letters improvement of more than 15, or also the loss of letters of 10 from baseline to 12 was less in aflibercept compared to the other anti-VEGF agents. So the mean change in baseline acuity from baseline to month 12 was around 8 letters improvement for aflibercept, whereas it was 5 to 6 letters in ranibizumab and laser. In dexamethasone, it was not compared. Laser was the comparison between these trials. Also, the CMT thickness was reduced more in aflibercept compared to the other anti-VEGFs. So aflibercept is the most favorable treatment in terms of best corrected visual acuity improvement and CMT reduction compared with other therapies in the management of DME within the first year. So international guidelines and recommendations suggest aflibercept should be the drug of choice in patients with visual acuity of 612 or worse. So these are the recommended guidelines by EURETINA that aflibercept is the drug of choice in DME less than 612. It shows superiority to other anti-VEGFs like bevacizumab and ranibizumab over 2 years. As in Asian population, the Asian recommendations, patients with worse acuity of less than 612, aflibercept may result in a more rapid visual acuity improvement than compared to ranibizumab over 1 year. Although in DRCR.net protocol T, we have found that over a period of after 1 year, all the anti-VEGFs have a similar effect, and none of the anti-VEGFs are non-inferior. So what we learn here is, although aflibercept may be a drug of choice, but in real world scenario, everyone cannot afford aflibercept, and hence the other drugs are not an option. It is an alternative to achieving the same result. Also, the Canada guidelines show that superiority of aflibercept was noted in the group of participants with worse baseline visual acuity. This superiority of aflibercept at year 2 with gains of 18 letters in aflibercept compared to 13 letters in bevacizumab and 16 letters in ranibizumab group after 2 years. Evidence for a possible difference in drug efficacy in patients with diabetic macular edema to the disadvantage of bevacizumab. What it means is, there is no disadvantage of aflibercept when compared to other anti-VEGFs. It is equally superior and it has better visual gains than compared to the previous anti-VEGFs. So can these guidelines and meta-analysis inform anti-VEGF treatment in clinical practice? So these are the data from Moorfields Eye Hospital and the FRB registry that was assessed for the efficacy of aflibercept in patients in clinical practice. So what we see here is poor patients with poor visual acuity as baseline, that is 612 and less. Up to 2/3 patients had shown improvement by 1 year. And the adjusted mean change in visual acuity among patients with more than 68 letters or 612 or worse at baseline, they received around 7 injections in the year 1 and 10 injections in aflibercept. So the adjusted mean visual acuity from baseline to month 12 in eyes with initial vision of less than 612 or significantly higher in eyes receiving aflibercept than in those receiving ranibizumab with a similar number of injections. So although patients received a similar number of injections, aflibercept was seen to have better visual acuity than compared to the other injections. Some other studies also showed that 57% of the patients were on 3 monthly interval regimes has been attained with the help of aflibercept than compared to other anti-VEGFs. So JADE trial, which was done in Taiwan to evaluate the treatment efficacy of DME, here they followed a TREX regime wherein the treatment was given as a loading dose and then followed by the prevalence of recurrence. So if there was recurrence, the interval was shortened. If there was no recurrence, the interval was lengthened. What they achieved was a 12-week interval between the duration of injections. So it is almost 3 monthly gap between two injections, which is actually very good as patients with diabetic macular edema usually require frequent injections and they usually require injections bilaterally. So patient requiring 3 monthly injections compared to every monthly injections is much better in terms of cost also and the burden to the patient also. So to summarize, aflibercept can achieve meaningful vision gains in patients with DME as demonstrated by any randomized controlled trials. Also, the meta-analysis and international guidelines suggest that aflibercept should be the drug of choice with patients having visual acuity of less than 612. The real-world experience also highlights the effectiveness of aflibercept in the clinic, where patients regularly present with poor visual acuity. Thank you.
Yeah, thank you, Dr. Abhishek Heranjal, for the wonderful presentation on DME. Sir, there are a couple of questions by the participants in the chat. First of all, from Dr. Kinjal, sir, what is your current treat and extend strategy with Eylea, and what criteria do you use to extend beyond 12 to 16 weeks? So, Dr. Mihir or Dr. Abhishek, anyone can take up.
Okay, so let me just read it once more. What is your current treat and extend strategy with Eylea, and what criteria do you use to extend beyond 12 to 16 weeks? So treat and extend strategy is that we have to just initially, when the patient comes to me, I explain him how the treat and extend works and what the studies tell us, how many injections would be approximately required in the first year and how many in the second year. And then we I usually do follow the loading doses, definitely when it comes to a CNVM or a wet AMD. First 3 injections are given with a monthly interval. And after that, I start extending. So what I do is after 2 months, I give one injection and I keep on monitoring at every visit when they come. I do keep on monitoring. And then if the visual acuity and if the disease basically is improving, that is the fluid is reducing, but it has not completely resolved, activity is still there, then I will maintain whatever interval I am giving the injections at. And if the disease has no activity at that very moment, when I'm comparing the OCT scan of that visit to the previous visit, and there is no fluid, no subretinal fluid, intraretinal fluid, then I can think of extending the interval. I will definitely shorten the interval when the fluid has increased, or if I see something like a new macular neovascularization or a macular hemorrhage. So these are the signs of activity. So in my practice, what I consider an activity most importantly is fluid in the intraretinal or subretinal compartment, an amorphous shrum which is increasing. I'm not talking about a discrete shrum which has the discrete borders. That is more pointing towards a predominantly scarring which is happening there, but an amorphous subretinal hyperreflective material with some fluid. So that is how I try to extend beyond 12 to 16 weeks. And it is very important to tell the patients that it is not something that we can 100% give a guarantee about, that we will just extend you. We say that we will try our best, whatever is proven and whatever the literature says, we will do according to that, and then the rest there is obviously inter-patient variability.
So in diabetic macular edema, to answer the same question, so I usually have a different approach to patients because not all patients would want a injection at a dry macula. So when a patient comes to you and he has supposedly a diabetic macular edema of a mild or moderate grade, you tell him that you are going to inject. This is definitely requiring an injection. You can choose whatever injection you have. But first, once you give an injection, you assess whether the OCT features have responded to the injection. If the reduction is more than 20%, the fluid is regressing, the patient's visual acuity has improved. So then, once you inject, I do not follow a 3 loading doses or a 5 loading doses for diabetic patients. I do follow it for CNVM or an AMD patient. But in diabetic macular edema, I just inject once, see how it has responded to the injection. If there is some residual fluid which is remaining, I re-inject and then again wait for it to become dry. So once it becomes dry, you assess over a period of 1 month to 2 months, because if you're giving Eylea, you know that the mechanism of action and the half-life of the drug is lasts for over a period of 2 months. So you don't re-inject always. You wait for those 2 months. If it is regressing over a period of 2 months, wait till it becomes dry. Once it becomes dry, then wait for another 2 weeks. Repeat an OCT. If it is coming back, then you know that the interval for this patient is around 2 months. Every 2 months, re-inject if the fluid is there. If it is not there, try and extend it to 2 weeks or beyond 2 weeks. That is how you do a treat and extend regime. But I do a little modified treat and extend regime. I do not follow the to the book treat and extend regime.
Yes, definitely. So what I feel is that eventually what happens and how the therapy is given completely depends upon patient compliance. And it has to be individualized, looking at the patient, what are his expectations. There are some patients who are very compliant. They say that you give how many injections you want, but when we explain, I usually explain when it comes to CNVM, I explain the patient that it is somewhat like diabetes. So, I mean, diabetes in your body, if the sugar control is not there, then it keeps damaging the organs. Insulin, if given properly, is not going to have any side effects, but if the sugar control is not there, it is going to damage your organs. And similarly, is the subretinal fluid, which is damaging the photoreceptors, causing RP atrophy, and then there is a damage which we could have prevented, and we are converting the treatable damage to a permanent damage every time when we are leaving fluid. And that is what I don't want to do with your eye. And if the patient is compliant, then we can give a very good therapy and maintain vision over long terms. But then that in real world scenario, it does not happen every time. There are some patients who are not very motivated for their therapy to be given in a treat and extend manner. So for them, PRN works best.
So the INU support program was very effective, and that actually helped me in my practice to actually continue or sustain with Eylea injections. Otherwise, the only treatment option that I had in my practice is either Avastin or ranibizumab, wherein the patient can at least afford and not deteriorate to such an extent that no injections will work.
Yes. So usually what I do is when a patient comes with a CNVM, I try to push for Eylea. I will definitely tell the advantages of Eylea and how it has proven to be very effective. And when a patient is coming with a inflammatory pathology like a diabetic macular edema or this thing, I will, for all patients, I'll give all options, and then depending on the affordability of the patients and also how much the vision is. So drcr.net, as you already mentioned in your presentation, multiple studies which were done, and also the drcr.net said that if the vision is worse than 6/12, the protocol T says that aflibercept is definitely better. So depending on for 6/6, 6/9, I don't push so much for aflibercept if they are not willing, but I definitely give them the option.
So on the OCT, whenever you see a neurosensory detachment along with the diabetic macular edema changes like the intraretinal cystic spaces and exudates, I would say Eylea would work better. Or even if not Eylea, at least I would give steroids like an IVTA if not affording, or Ozurdex. But if there is no neurosensory detachment, I feel any injection will work well. But if there is an NSD, it demarcates that there is some part of inflammation which is also happening in the eye, and you have to curb that. And Eylea is one good injection which is like targeting all these markers. So hence, Eylea would be the choice of drug. But when you come to affordability, you have to always take a pick between either Avastin versus IVTA versus Eylea. So better than not giving any injection. Do not always force a patient. You have to take this. There is no other choice. You give some injection, and probably the number of injections will increase, but you'll get the desired result.
Yes, something is always better than nothing. We have to in certain patients.
Yes. We can
Dr.
move.
Dr. Khurana from Dahod, Gujarat is asking, how do you counsel patients regarding expectations for visual improvement versus disease stabilization to both the respective speakers?
So see, diabetic macular edema, I'll say ki it is a multidisciplinary approach. You have to understand that diabetic macular edema is not just increased sugar levels will cause diabetic macular edema. If there is anemia, even then there will be worsening of diabetic macular edema. If the patient has habits of alcohol or smoking, the increased antioxidants will also cause damage to the blood vessels and further increase the diabetic macular edema. If the patient is on a kidney failure or chronic kidney disease also, the patient or nephropathy basically, then also the patient is going to worsen. So you have to tell the patient your lifestyle, your other systemic diseases, along with the sugar control, everything is going to matter with the outcome. So even if I give you injections, I give you the best injection in the world. If you do not control your sugar levels or you do not have a good lifestyle, your injections won't work. As simple as that. So outcomes should be very realistic. You cannot, don't promise them stars when you know that the possibility of him, an obese patient, is not going to do exercise or he's not going out of his bed. He likes his luxurious life. He does not want to go anywhere. He's just ready to pay. He's not going to gain the same results as anyone else who is going to work on himself.
Yes, lifestyle changes, diet control, and all these definitely form a very important thing when we are considering diabetic macular edema. And for RVOs and everything, one thing which I have started doing routinely, even in my diabetic patients, is I just measure their serum homocysteine also, along with all the other things with lipids, sugar, and everything. Serum homocysteine, I have seen in the last few years that many young patients, 40-year-old, 35-year-old, 50-year-old, are coming with RVOs and their serum homocysteine is much, much more higher than 25. So
And they
that
won't
is,
have hypertensive changes. They will just have raised serum homocysteine.
yeah, just serum homocysteine. And as far as AMD is concerned, yes, we should. I do tell them to decrease this thing, smoking and tobacco chewing and all those things which actually affect. Rest genetic factors are not in our control. And the most important thing when I start an injection therapy is I explain them that they should be compliant to the regimen. The regimen will do justice to them if they do justice to compliance. They should be compliant, and every time we are leaving fluid, which is there on top of those photoreceptors, it will keep on damaging them. So we don't want fluid. Just like comparing to a disease which is chronic and much well understood in a population, in a layman population like diabetes, really helps when we are talking about an AMD, because AMD is just a very new thing for them. Diabetes is something which is heard, and they all know that sugar controls have to be maintained. So dry maculas also have to be maintained.
So I would like to add that whenever there is a myopic CNVM compared to age-related macular degeneration, myopic CNVMs respond very well to injections. They might require fewer injections. They become stable much more quicker than compared to age-related macular degeneration. As Dr. Mihir said, you have to stick to the protocol. 3 injections, मतलब 3 injections लेना है. You cannot think कि 2 injections से चल जाएगा क्या. You have to take 3 injections. Post the 3 injections, you may always take a planned decision, as in like you want to follow the PRN regime or the TREX regime, whatever you want. You can also switch to a lower anti-VEGF if you are not affording. That will still work, but completely stopping the treatment till you wait till there are patients who want to take Eylea, but they don't have the funds for it, and they'll wait 2 more months to get the funds, and by that time the fluid increases such a level that they may require more than 2 injections. So that should not be the case. If you are not you cannot afford an injection, take the simpler one that will still be efficacious than compared to just waiting for the best injection.
So in myopic CNVMs, do you still follow the loading dose or do you go PRN from the beginning?
From the beginning, PR.
They respond very quickly. Somehow they regress and they don't usually recur very much also. And one more thing, for RVOs, there is this thing called, even after the dry macula, one more injection is being given as the maintenance dose. Do you follow that?
I don't follow that, but I have seen one patient wherein there was an impending CRVO. He had very little cystic spaces at the macula. Vision was 6/9. I gave him an injection and it imploded. So post injection, he worsened. So either it was anyway going to worsen and I injected, or it was just a circumstantial thing that happened. So some people also say that in ischemic cases, you should not give an anti-VEGF, rather give a steroid. That works better. But then it is all, there is no clear-cut evidence that this will work better, steroids will work better, or anti-VEGF will work better. Because I have patients with CRVO who have, the same patient has responded very well to Avastin. The same patient the next month has responded very well to Eccentrix. The same patient to an Ozurdex implant. Same patient to an Eylea injection. So no matter what injection you give the patient, he's improving. But the only point is his visual acuity is dependent on how much vascularity he has at the fovea. So angiography plays a very big role in identifying those patients who are anyway not going to improve with any injections. So if you do an angiography post any injection, you will understand whether the foveal avascular zone is actually enlarged or it is ischemic. There is presence of macular ischemia or what. This is how I usually tell my patients that which injection is better for you or which has worked for you.
Okay, that's great. I have this patient who is on 6 monthly injections. It's an RVO patient, and for the last 1 or 2 years, that patient is needing an injection. So it gets controlled. Initially, we gave some 3 or 4 injections, and after that, it remained controlled. And after 6 months, it again came back. So I looked in detail if there is any area of CNP area or any area of ischemia. I did an FFA also for that patient. Why does it keep recurring? If it stays stable for 6 months, what happens after 6 months? So that patient is still a mystery, but still happily taking Eylea every 6 monthly as long as vision is 6/6.
So this CRO patient that I was talking about is a similar case. I followed him up for 3 years. Every 6 months or 5 months, he is requiring an injection. Every time I give an injection, the visual acuity comes back to 660. But the frequency of injections was every 6 months. So angiography, I have done angiography thrice for the patient at an interval of 3 months. Never seen any increase in CNP areas or anything like that. No NVs or NVDs anywhere. But macular ischemia was always persistent.
Okay.
That patient, I did a prophylactic PRP for him because I said probably if you do not come back to me, at least you should not worsen with a NVG. So I did a prophylactic PRP. Post that PRP, it has been 8 months now. He has not required an injection. So probably, even though there is no CNP, definite CNP areas, there is a sort of ischemia in the periphery that is not being picked up, or which is very subtle. That is why the edema is very slow.
So I think some scatter peripheral
Scatter
photocoagulation, which is like far away in the periphery, should help my patient
Yes.
also.
I was more worried that if he has some peripheral vision because of macular ischemia, he does not have very good central vision. If I do an aggressive PRP, he will lose his peripheral vision also. But that was not the case. He still is able to see the same areas. So probably we just have to reevaluate and understand CRVO much better.
Yeah, definitely.
Yeah,
We can-
one question from Dr. Ashish is that Zydus biosimilar, we have heard that there are some adverse event observed in the new batch as well. Have you tried it?
Are you talking about the Anaira or the?
Yeah. Zydus one, yeah, Anaira only, sir.
Okay. So as of now, I have given around 12 to 13 Anairas, and till date, the same batch also I have not had any complications or any inflammations or any adverse events which have led to a decision of not giving Anaira anymore. And I would not say it is equally efficacious as aflibercept, but what I have seen is it is at least working for now.
So I don't have an experience with Anera. I usually then, if the patient is not affording, I go back to the trusted biosimilar. That is, I go ahead with a Razumab injection or something like that. Either, but you
do
think
you
it's
go back to
better than
Razumab?
a different biosimilar like a Razumab, Anera?
Anaira is better than Razumab, definitely, because it has a longer duration of action. The molecule is the same. So anyway, it will work for 2 months. So that is the advantage that you have. Plus the cost is lower and it is an approved drug. So when it comes to medical legal obligations, when you have a choice between Zaltrap versus Anaira, I would give Anaira. Because Zaltrap is definitely worked. It has been proven that it is equally efficacious as I would not say equally efficacious, non-inferior to aflibercept. So when we have a molecule in the market which works equal as aflibercept, why not Anaira? When it's a biosimilar of the same compound. So you just have to develop some trust in the molecules and wait till the actual real world experiences come out. It is too early for now because it's just been 6 months.
Yeah.
I have just given 13 injections and that has been only 2 months. And I have to still wait for recurrences and probably a second Anaira injection. Then I'll come to know whether it's working or not.
So I feel for Anaira, we know that it works, it decreases the edema, but we don't know how durable it is. Like how much can we extend the duration? Like can we go to Q12 eventually? Can we go to Q16? So
Correct.
it's not it's, we can try that in patients who are not affording and stick to aflibercept in patients who are willing. Is
Those who
what I
can
usually
afford,
do.
go for Eylea. Those who cannot afford, go for Anaira. Those who cannot afford that much also go for the lower. That is the real world experience. That's it.
Yes.
Because I think Zaltrap is being given for 10 to 15,000. The Anaira injection is somewhere between 25-30 and Eylea is between 40-45. So 10,000 difference between each injection does make a difference for a patient's decision making.
Yeah, definitely.
Thank you so much, sir, for taking up the questions. And so there are no more questions, so we conclude today's session.
I would just like to add also that the new batch does not have any complications as of now. The previous batch also, the verdict was that the injections were procured through a CGHS program where the patients get the injections in their hand. So probably there was a problem with the cold chain,
Cold chain.
and that is why the patients developed some intraocular inflammation. None of the patients lost vision or anything. They was just having some vitritis and some intraocular inflammation, which was curbed with the help of steroids. So that is what I have understood from the recent conference that I attended. And as of now, there is no serious side effect wherein there is reports of blindness or endophthalmitis or anything of that sort. So you can safely give Anaira for now.
Okay.
Yes, sir. So there are no more questions, and with this, sir, we conclude today's session. And I would like to thank both the speakers, Dr. Mihir Vaidya and Dr. Abhishek Heranjal, for their wonderful presentations. And I would also like to thank all the participants to take out time for today's meeting. And thank you once again, and wishing you all a pleasant evening.
Sushil bhai, before that, I would like to thank Dr. Mihir, as he rightly shared that Eylea is definitely has having 10 years of experience like in India only. So you can predict the results as compared to like other biosimilars. So that thing we can probably say, sir.
100%, because diabetic patients are getting an increased interval of more than 24 weeks in my patients.
Yeah, sir.
So, and the meta-analysis of DME says that 16-week to 12-week interval is usually there. I have seen more than 24-week interval. So, not every patient fits the same category as criteria. You have to evaluate the other factors also. So, I'm just waiting for patients to receive fewer injections. So I'm waiting for Eylea IG when we can inject once a year or half yearly one injection. लो आपका DME control में रहेगा.
Absolutely, sir. Thank you so much, sir.
Thank you.
Okay.
Thank you.
Thank you.
Thank you, sir.
Thank you so much, sir. Thank you, Mihir, sir. Thank you, Dr. Abhishek.
Yes.
Tech team, we are good to close.
Okay.
Thank you, sir.